A very good afternoon to all of you. I am going to speak on the primary site local therapy for de novo stage 4 breast cancer. So, the results of the prospective clinical trials. Next slide. So, about 6% of new breast cancer diagnoses in US are stage 4, and the median 3-year survival in 2011 was 40%. But in these patients, the intact primary tumor, it aids in diagnosis as well as the biologic subtypes also influences the selection of systemic therapy, as well as it can cause various symptoms and affect the quality of life. Till 2001, there is no formal analysis of the value of local therapy to the primary site in the stage 4 breast cancer patients. Next, please. So the NCDB data 1990 to 93, they analyzed the survival in stage 4 patients. They found that the median survival even in total mastectomy patient is 13.9 months and have the significant benefit in negative, positive and negative margins. Next slide, please. So the primary tumor resection in stage 4 breast cancer, is there a consistent benefit or there is a consistent bias? Next, please. So the sources of biases in the retrospective data, it might be the better physiology like age, comorbidities, better access to care like invalid or insured, or a better biology of tumor like hormone receptor, HER2 status, grade, or might be due to lower metastatic burden like there might be bone-only disease or oligometastatic disease. These are at best only approximately measured in retrospective data. Next, please. So in NCDB data 2021, the new retrospective analysis, they have analyzed 12,838 patients. They divided into two arms, one in systemic therapy alone, systemic therapy and radiation, and the next arm they have divided systemic therapy and surgery, systemic therapy, surgery and radiation. Next slide, please. Based on this data, the main message of this paper is that the trimodality therapy is the best with chemotherapy when it is given before the surgery. But the surprises are that the oligomeds in 38% of patients in these paper, and the systemic therapy used in 28% of patients in 2010 to 11, and from 28 it is increased to 40% of patients in 2014 to 2025. Radiation as locoregional seems undistinguishable from radiation at the distant sites. Next slide, please. So, the various prospective trials which are addressing the use of locoregional therapy for the intact primary tumor. Next, please. So there are few randomized and non-randomized trials like Tata Memorial MF0701 positive E2108 JCOZ 1017 and two non-randomized, that is TBCRC and MF1401. So next please. So the randomization design in all these groups, they have divided into two designs. Like first, they are registered the patient and given the primary systemic therapy, and the second registration if there is no progression. And in the second design, they have registered the patient into systemic therapy alone, and the second arm is resection of primary tumor upfront, and further they continue the systemic therapy. Next, please. So the trials with the upfront systemic therapy, the two trials like from Tata Memorial from India and E2108. So in Tata Memorial paper, they have included the resectable post-anthracycline based chemotherapy. And they have included less than 3 organ sites, no extensive liver mets. They excluded if single metastatic lesion or amenable to local therapy. In E2108, the resectable post-physician determined optimal systemic therapy, and all patients, they must have the expected survival of more than 6 months, and biopsy is required if single metastatic lesion. Next, please. So, in both Tata Memorial and ECOG Acrine 2108, they have done a registration at first step and second, then randomization in second step, and then they divided the arms into continue the systemic therapy and in second arm the early local therapy. And in the local therapy, they have done MRM or BCS plus minus and axillary dissection plus minus post-op RT as for non-metastatic disease. Both arms they have designed in the same way. Next slide, please. So in both, they have used the upfront systemic therapy, and they found that there is no survival advantage benefit in both the Tata Memorial as well as EA2108 trial. Next, please. So in the next trial, the Turkish Federation MF07 and ABCSG28 positive trial. So Turkish has reached its full accrual. They again have randomized in continuing the systemic therapy and the second arm, the early local therapy, and they have analyzed the efficacy analysis population. And in positive trial, it is halted for low accrual, and they have only included the 90 patients, and in the same way of randomization they did. And in local therapy, MRM or BCS or sentinel lymph node biopsy allowed, if allowed, then axillary dissection if indicated, and post-op RT non-metastatic site. Next, please. So, in Turkish Federation trial, this trial favors the use of loco-regional radiation, but the positive trial, it favors the systemic therapy. Next slide, please. So when we closely evaluate at its these two papers, then we find that in Turkish trial, that is MF0701 trial, they have included the maximum number of hormone receptor positive tumors. HER2 positive triple negative are only 7%, and bone only mets is 51%. So they have shown the survival advantage. But in EA210, might be they have not chosen the better biological favorable tumors. Next slide, please. So when we do the subset analysis in MF0701, which favors the treatment of loco-regional therapy, we found that ER positive tumor had better survival. If the age is less than 55 years, better survival. Bone only mets and single bone only mets, they have better advantage. Next slide, please. So even EA210 trial, 2108 trial, they have evaluated their overall survival by tumor subtype. For 20 women with TNBC, the survival was worse in the early local therapy arm. And for 47 women with oligometastasis, there is no difference in survival by the arm. Next slide, please. But the four trials, Tata Memorial, ECOG 2108, and an FMF 0701, they all three, they have shown there is a local control advantage. But positive trial, they have local control similar, and it has low accrual, and so many biases are in there. So basic point is the local control advantages is found in the both of the three trials. In spite the Tata Memorial and ECOG, there is no S advantage, but still the local control advantage still persists. Next, please. And the quality of life data from the positive and E2108, 2108, both of these papers, there is no quality of advantage in both of these. Next, please. So we discussed all the randomized trial. Now we are discussing the non-randomized trial. Next, please. So the first is TBCR data, where they have taken de novo stage 4 patients, treatment by physician and patient choice. They have included 112 patients, 46% bone only mets, and 57% have single organ mets. And the first line therapy they have given either in the form of endocrine only in 46% and trastuzumab in 25%. And if responders either in CR, PR or stable disease, they underwent elective surgery or no surgery. So non-responders have 13 months of median survival and 24% of 30 months survival. Responders without surgery, 65 months of median survival and 76%, 90 months survival. And the responders who underwent surgery, that is 39 patients, the 71 months median survival and 77% is the 30 months survival. Next, please. So second is the BOMET trial, that is bone only disease MF1401 trial. This is a multi-center prospective registry study. They have included the de novo stage 4 but bone only metastasis. They divided their group in two arms, one in systemic arm and one in loco-regional treatment arm. In loco-regional treatment arm, they have further divided into two arms, systemic therapy before the loco-regional LRT or systemic therapy after LRT. and only the 6% of the patient they have confirmed the bone mets by biopsy. Rest of them is confirmed by PET CT and bone scan, and the systemic choice is on physician's choice. So they have taken a solitary bone mets. In both cases, there is no significant difference in hormone receptor or HER2 status or histology at 34 months. But next slide, please.
Dr. Rashmi, can you sum up in a minute?
Sir, 1 minute. I will take 1 or 2 minutes. So MF1401 result, it shows that the locoregional therapy is better as compared to standard therapy. And when the systemic therapy is given before the locoregional therapy, it has added advantage. Next slide, please. So they all have shown that the favorable results. Next, please. Next, please. So next, please. So putting it all together, if we conclude the available level 1 data provide little justification at present for a physician recommendation from primary site locoregional therapy as a means of extending survival. Although the local control is improved by the use of primary site LRT, so far this has not translated into improved quality of life. So the primary site LRT can be considered if the primary tumor is progressing, but the distant disease is well controlled on systemic therapy. So this JCOG 1017 trial results, it is expected to come in the next years. And oligometastatic or bone only disease may present distinct subtypes like in BOMET study where locoregional control influences survival, but this remains to be proven. Thank you. Thank you so much, sir.